Neonatal Resuscitation Part 2. We have discussed the temperature part T, then we discussed A, airway, we discussed B, breathing, and now circulation. For circulation, to maintain circulation, you may need to give, silence please, you may need to give positive pressure ventilation. This is to be given at the rate of 40 to 60 per minute. What is the aim? To maintain heart rate more than 100 per minute. And the devices you may need is ambu bag, or in some cases you may need to put in the endotracheal tube also. You will be putting the endotracheal tube only when this bag and mask ventilation itself is not sufficient. So then if heart rate is still below 80-60, you have just tried to understand, you have done bag and mask ventilation, adequate bag and mask ventilation. What does this mean, adequate? Adequate means you have done it properly. Let us say you are doing it with the ambu bag and the air is leaking out from the mask that you have placed around the face of the child. This means adequate is not there. Or bilateral chest, both side chest expansion is not taking place. You have not maintained the correct slightly extended position of the baby. So these factors might come into play and the ventilation may become inadequate. So if you have been giving the adequate ventilation and still heart rate is below 60 to 80, and then you will do chest compression. What is the height of the baby? If you draw a line across both nipples, slightly below it will be the lower 1/3 of the sternum. So that is the position where you will be giving the chest compression. There are two methods. One is you can hold it like this and do compression. Second is you can do by these two fingers. You have to press. How much you have to press the chest? That is 1/3 to 1/4 of the chest diameter, the chest height. That is approximately 1 to 2 centimeters. So you will be doing a compression at the rate of 90 per minute. The ventilation will be taking place at the rate of 30 per minute. So the ratio will be 3 compressions to 1 ventilation. The depth, as I already told you, 1 to 2 centimeters. The position, the child should be placed on a firm surface. Only then you will be able to do the chest compressions properly. Sometimes if you are not doing it properly, there can be these two complications of chest compression. What is, you may fracture the ribs of the newborn if you have applied too much pressure, or you may also cause pneumothorax, right? So coming to the ET tube size, I showed you the ET tube in the last lecture. So the internal diameter is what you require. If the child weight is less than 1 kg, you will need 2.5 mm. If 1 to 2 kg, 3 mm ET tube, 2 to 3 kg, 3.5 and more than 3 kg, you will be needing 4 mm ET tube, right? Now how much to go inside? What should be the depth of the ET tube? Usually it is 7 to 12 centimeters. But if you want to calculate as per weight, the weight of the child plus 6 centimeters. Let us say it is 2 kg child, then 6 plus 2 is 8 centimeters. You will be introducing ET to 8 centimeters. When to use the ET tube? That is पॉजिटिव प्रेशर वेंटिलेशन आपने ET ट्यूब से कब शुरू करना है? इफ़ द हार्ट रेट इज बिलो 60. देयर इज अ मेकोनियम एस्पिरेशन सिंड्रोम, डायफ्रामेटिक हर्निया और बैग एंड मास्क वेंटिलेशन दैट यू हैव बीन डूइंग adequately, that is becoming ineffective. Extremely low birth weight babies with gestation less than 32 weeks, severe respiratory distress, respiratory failure. So you have to be careful that the laryngoscope that you use is the newborn one. You are not using the adult laryngoscope. The difference is that the blade of the newborn is straight, whereas the laryngoscope blade of the adult one is curved one. It is straight. I showed you in the last lecture. Then for a preterm you will be using blade of size 0, and for term size number 1. You will also need the suction catheter. Now how to introduce the ET tube? The child should be in neutral position, straight. The neck should not be tilted to this side or that side. It should be straight and slightly extended. You will hold the laryngoscope in the left hand. This is how you can use your left hand. Just so like this. You will be holding the laryngoscope like this. The blade will be in front. Let us say the child is head is toward you and the feet are toward the other side. So you will put the laryngoscope into the mouth like this, and then you will slightly lift the internal larynx etc. by mild force, and you can also press upon the hard bone. The idea is that you are able to see the vocal cord. When you are able to see the vocal cord, you will introduce the ET tube with your right hand. Just under direct vision, you will introduce it. The length we have already discussed. Now, how to confirm that you have placed the endotracheal tube at the right position? If you will use it without properly watching the vocal cord, you may even sometimes put it into the esophagus. So that will not give you any respiration. It will be only inflating the stomach. So the depth should also be proper. Why? Because you want to inflate both the lungs. If you go more deep and then you will introduce the ET tube into one bronchus. Let us say this is the trachea. From here this is the left bronchus, this is the right bronchus. If you are just before the bronchi, then air will be going to both the bronchi. If you go more deep and you introduce ET tube, let us say to the right bronchus, then whole of the resuscitation, air will be going to the right bronchus and the left side lung will remain unexpanded. So this is very important, you confirm the correct position. What is the method? First is, as you will be after putting the endotracheal tube, now you will attach it to the ambu bag, you will press on the ambu bag, it will push air. You have to see the both the chest, right and left, whether there is a chest rise on both sides, equal chest rise. जैसे ही आपने प्रेस किया ऐसे करके चेस्ट राइज होगा, फिर आपने छोड़ा, it will settle. Again you press, chest rise. Now let us say one side is moving and other side is not moving. This means the position is not correct. So this is one method that you see the chest rise. Second is you can do the auscultation. You are doing the pressing the ambu bag. You will need one assistant also. Either he can check the air entry on both lungs by auscultatory method, or he can place the stethoscope in both of your ears. You can also yourself hear. The air entry on both sides should be equal. Third is, if you are not able to confirm, especially in low birth weight preterm babies, you may do X-ray for confirmation, because subsequent your ventilation and all other efforts will depend on the correct position of the endotracheal tube. Even sometimes if facilities are there, and tidal carbon dioxide can also be measured. That is, what is this? That when the child expires, does the expiration phase में उसके जो एयर है उसमें कार्बन डाइऑक्साइड कितनी है. One clinical finding that will help you that you are in the right path, there will be prompt rise in heart rate. So the precautions is, you should not either do very flexion or very extension. It should be slightly extended position and the child in neutral position. 20 seconds. What does it mean? That you should be capable of doing it as quickly as possible. Don't waste time more than 20 seconds, because it is a question of life and death for the child. So when you are putting the ET tube, the other person should be giving the child free flow oxygen, so that oxygen saturation of the child doesn't fall. Now the third part, last part, fourth part, that is drugs. We have discussed temperature, airway, breathing, circulation, and now coming to the drugs. So regarding the drugs, first one is epinephrine. What is the indication of these drugs? Again same, if heart rate is below 60. आपने पॉजिटिव प्रेशर वेंटिलेशन किया, फर्स्ट किया आपने बैग एंड मास्क से, फिर आपने देखा उससे नहीं हो रही, देन यू पुट इन द ET ट्यूब, उससे बैग एंड मास्क पॉजिटिव प्रेशर वेंटिलेशन दिया, फिर उसके बाद कि अभी भी इवन इन स्पाइट ऑफ 60 सेकंड द हार्ट रेट इज़ नॉट राइजिंग अप, तो क्या करना है? यू विल बी यूजिंग द एपिनेफ्रिन. जो कमर्शियली प्रेपरेशन अवेलेबल है, दैट इज़ 1 in 1000, but you will be using 1 in 10,000 preparation. How will you prepare? You will take syringe, 10 ml syringe लेंगे, उसमें 1 ml you will be taking the adrenaline and rest 9 ml with the normal saline. So automatically it will be 1 in 10,000. So epinephrine drug, the dose is 0.1 to 0.3 ml per kg. It can be given IV, it can be given but intramuscular is usually not preferred. You can give by the umbilical vein also. And what is this? Intrathecally also. Directly into the respiratory passages you can introduce. What are the three effects of epinephrine? It is inotropic, vasoconstrictor and chronotropic. The response takes place within 30 seconds only. It is so quick, heart rate will rise more than 100. If doesn't increase, you can repeat it also. Right? If still it is not, child is not coming up, heart rate is not improving, then probably the child is going into hypovolemia or acidosis. This we will discuss next time. Okay, thank you. If you want to ask, you can.